colleagues are going to discuss with you the clinical scenario of head neck phase, and in that my topic is trauma and emergency. First, the fracture of skull. There are three types of fracture of skull: the depressed fracture, the linear fracture, and basilar fracture. As you can see in the picture, the three types of fractures are mentioned: the linear fracture, depressed fracture, and the basilar fracture. The depressed fracture is a type of a skull fracture in which the part of a skull bone is pushed inward towards the brain side. It is a fracture where the bone fragments are displaced inward, sometimes pressing on or injure underlying the brain tissue. The causes of this may be the road traffic accident, fall from height, sport injury, or hit by any heavy objects. Most common side of this is the parietal region, because the bone is relatively thin and is frequently injured in any type of assault. And if the depression is more than the thickness of the skull bone, then usually surgery is required. Second, the linear fracture. The linear skull fracture is a simple fracture in which there is a thin crack in the skull bone without displacement of the skull bone fragment. Causes of this may be the direct blow to head, accident, and if you have to identify, when you see the X-ray or CT scan of a linear skull fracture, then you will find a line. This is how you can identify the fracture, linear fracture. Common side is the parietal bone and the frontal bone. This is the most common type of a skull fracture and usually does not require any type of surgery. A basilar fracture. Basilar fracture is a fracture involving the base of the skull, floor of the cranial cavity. Causes of this may be the severe head injury and fall from height, etc. It is usually serious because many cranial nerves or blood vessels pass from these areas. That's why it is more serious. The common sites are the temporal bone, which is most common. Sphenoid, occipital, ethmoid are also involved. Sign and symptoms of these are battle signs, bruising behind the ear, which means the bluish or purple color discoloration behind the ear over the mastoid region. Recognize periorbital ecchymosis, which means the black eyes, CSF rhinorrhea, CSF leak from your nose, CSF otorrhea, CSF leak from your ear, cranial nerve palsy, especially the facial nerve. Facial trauma. Injury to the soft tissue, bones, organs of the face due to the trauma. Common cause of this may be the road traffic accident, assault, fall, or sport injury, etc. Common fracture sites are nasal bone, which is the most common, zygomatic, maxilla, and mandible. Complication, airway obstruction, CSF rhinorrhea, and infection, vision problem, etc. Management, basic principle, ABC first. You have to first check the airway, breathing, and circulation. Control bleeding, imaging, X-ray or CT scan, and if requires, you have to do surgical fixation. Thank you.
Good afternoon, everyone. Myself, Ashad Khan, roll number 51, and today I am going to present neurovascular disorders. Neurovascular disorders involve abnormalities of nerves and blood vessels, which leads to the clinical scenarios like stroke, trauma, paralysis, pain, and infectious spread. Important neurovascular anatomy: arterial system, common carotid artery, internal carotid artery, and external carotid artery. Venous system contains cavernous sinus, internal jugular vein, and cranial nerves. Cranial nerves 3rd, 4th, 5th, 6th, 7th, 9th, 10th, and 12th. Carotid artery stenosis. Narrowing of carotid artery most commonly due to the atherosclerosis. which leads to the reduced blood flow to the brain and is increased risk of stroke. Cavernous sinus thrombosis. Cavernous sinus thrombosis. Cavernous sinus thrombosis is a life-threatening condition in which a blood clot forms inside the cavernous sinus, usually due to the spread of facial or sinus infections. Trigeminal neuralgia. Trigeminal neuralgia is a sudden electric shock-like facial pain occurring along the distribution of the trigeminal nerve. Trigeminal nerve have three divisions: ophthalmic, maxillary, and mandibular. Facial nerve palsy. Facial nerve palsy. Facial nerve palsy is the loss of facial muscles movement caused by damage to the seventh cranial nerve, resulting in the dropping and weakness on the side of the face. Thank you.
Good morning, everyone. Myself, Sandan Kunal, roll number 58. Today I will be discussing infectious and inflammatory conditions. First of all, I will be discussing retropharyngeal abscess. Retropharyngeal abscess is a collection of pus in the retropharyngeal space, that is space behind the pharynx, usually due to infection. Causes of retropharyngeal abscess. First of all, upper respiratory infection, tonsillitis, pharyngitis, trauma, that is fishbone injury, spread from lymph node, that is most common in children. Clinical features: fever, sore throat, difficulty swallowing, drooling, neck stiffness, muffled hot potato eyes, stridor in severe cases. Treatment for that is IV antibiotics, surgical drainage, in large abscess, airway management, which is most important. Secondly, I will be discussing calcific tendinitis. Calcific tendinitis is a condition in which calcium hydroxyapatite crystals deposit within a tendon, leading to acute inflammation and pain. Most common sites: supraspinatus tendon around the shoulder, rotator cuff, which is most common in 30 to 50 year age group and slightly more common in females. Calcific tendinitis has three stages: pre-calcific stage, calcific stage, and post-calcific stage. Pre-calcific stage, that is tendon undergo fibrocartilaginous change. Calcific stage, formative stage. In calcific stage, there is a formative phase, resting phase, and resorptive phase. Post-calcific stage has healing and remodeling. Clinical features: sudden severe shoulder pain, night pain, restricted shoulder movement, tenderness over great tubercle. Treatment for that is conservative is first line, rest, NSAID is physiotherapy, local steroid injection. Thank you.
Good afternoon, everyone. Myself Krishna Kadam, roll number 56. Today I will be presenting oncological and neoplastic cases. The tumors which are commonly seen in head and neck face are arises from oral cavity, oropharynx, salivary glands, and skin. The most common malignancy seen in head neck face is squamous cell carcinoma. Oral cavity squamous cell carcinoma can be seen. The common sites of the most common site of oral cavity carcinoma is lateral border of tongue, the floor of mouth, buccal mucosa, lower lip. The anatomically we can see that the rich lymphatics are present in level 1 and level 2 nodes. The mandibular invasion is possible during surgical procedures. The oropharyngeal squamous cell carcinoma, the common sites are soft palate, tonsillar region, the base of tongue, where we can see early nodal metastasis and possible glossopharyngeal nerve involvement is also seen. Salivary gland tumors. There are two types of salivary gland tumors. The most common benign tumor is pleomorphic adenoma, which is a painless and slow-growing tumor. Whereas the malignant form of this tumor is mucoepidermal carcinoma, in which facial nerve palsy may occur. Skin malignancies. The types of skin malignancies are basal cell carcinoma, squamous cell carcinoma, and melanoma. The common sites are nose, cheek, lower lip, and forehead. The risk factor here involved is chronic sun exposure. The spread and clinical correlations of these cases are: the spread can be mostly seen through lymphatic spread, which is the most common spread, local invasion of tumors, perineural spread, and hematoma spread, which is late in the course. The clinical clues for diagnosis of these cases may be: the non-healing ulcer we may refer as oral squamous cell carcinoma, and the parotid mass plus facial weakness can be considered as a malignancy. Thank you. The next presenter will be Yogesh Korde.
Good morning, student. My name is Yogesh Korde and roll number is 52. I will present you the clinical. I will present you the structure and congenital disorder of the head piston. So the structure and congenital disorder of the head piston. This is arises due to the abnormal embryological development of the pharyngeal arches, urocrustes, facial prominence, or skull bone. This may affect the bone, soft tissue, muscle, vessel, nerve, and the gland. So, I will discuss about the first disease. It will be the cleft lip and cleft palate. It is a common congenital. It is a common congenital defect. Inside there is a lip and the upper part of the mouth, that is the palate, or both do not move during the early of the pregnancy. It will cause an opening or a slit. The causes will be the failure of the fusion of the facial process during the 4th to 10th week of the intrauterine life. Embryological basic cleft lip. It will be the failure of the fusion of maxillary process with middle nasal process. And cleft palate. It will be the failure of the fusion of the palatine shear. So the type will be the unilateral, bilateral, complete, incomplete, and isolated cleft palate. So the clinical feature, it will be the difficulty in feeding, nasal regurgitation, and speech problem. So treatment will be the surgical refill. It means the surgical refills. It means the it can consist of the cheiloplasty and palatoplasty. Cheiloplasty means the surgical method on cleft lip, and palatoplasty means surgical method on cleft palate, and is a speech therapy. So next one, this will be the branchial cleft anomaly. It is a persistence of the bronchial apparatus remits. So type will be the branchial cyst, branchial sinus, and branchial fistula. So common site is along the anterior border of the sternocleidomastoid muscle. Treatment will be the surgical incision. It will be the complete removal of the cyst by coming out with the help of the surgical instrument. So the thank you for all the students for your attention, and thank you for our respected sir and ma'am. Thank you for the special for the Piyush sir for their guidance.
This was very informative and good learning experience for and I think for me also. Personally, I really like that case, the second wala, and even the applied anatomy, and we covered lot of topics which were very important as it's clinically for first year, second year, third year, and even later. Any other staff member wants to comment? Piyush sir?